Why would someone want medical assistance in dying?
Because they want to forego all of the suffering.
I worked in long-term care a long time, so I've seen many people die a long time and they're in pain.
I don't think it's right that people should not have the opportunity to choose when they die.
If that's their ultimate end is death, I say let's help them.
Medical assistance in dying, so much to know, so much to understand. Our expert today will help us understand the complexities and the intricacies of this program that is based in compassion. Well, Willie, thanks so much for being part of the show today.
Thank you for having me.
Now, can you explain to us what is the MAID program?
That stands for Medical Assistance in Dying. MAID, or Medical Assistance in Dying, has been legal in Canada, across Canada, in all of the provinces and territories since June of 2016. So it's been in place for 3 years and a few months already. So most often these individuals are very ill. They may have a life-limiting or life-threatening disease or disorder, and they're thinking about their end-of-life options. And they may be considering an assisted death. There are a number of ways to become referred to an individual, a provider like myself or a physician. Someone may call the Provincial Care Coordination Service. The ministry has set up a 1-866 number. A nurse on the other end of the line will collect some information and then move your referral forward.
If someone was very depressed,
Yes.
And just felt emotionally overwhelmed with life, they may not be eligible for this.
That's correct.
Okay, so what's some of the criteria?
Yeah. So currently one must have what's called a grievous and irremediable health condition, and that is a mouthful.
Yeah.
Grievous as in it's very serious and it causes suffering, and irremediable as in it's not going to get better. One must make this decision themselves. They can't be pressured or coerced by anyone. There may not be any pressure from anyone. It has to be a personal decision. And also one must have capacity. That is the brain power or the thinking power to be able to make a serious decision like this.
When that puts you in quite a role of this assessor,
Certainly.
because you're looking into a person's eyes and their soul in a way to hear where they're coming from, as well as you're looking at all the data.
Absolutely.
Yeah.
Yeah.
Okay.
It's very important to do a detailed assessment, and that is to be certain that the patient, the resident, whoever is asking for it, meets all of those eligibility criteria. There are some people who aren't eligible, and it's very difficult to give them that news that they're not eligible. Folks should know, though, that if one assessor like myself finds someone not eligible or ineligible, they have a right to ask for another assessment.
Okay.
And so just because I say they're not eligible doesn't mean that they're not.
So say now a person has completed all of that administration, all of the approvals have happened. Do they just simply pick a day and a time?
Well, there's another safety feature built into it so that folks don't get a diagnosis of something serious one day and ask for an assisted death the next day. They may ask,
sure.
but they won't receive it. So there's a reflection period that begins the day after that formal request is signed. And it's a required 10 clear day reflection period.
So once they've had that they passed the 10 days and they're giving permission is really what they're being given. They what if they were to wait a couple years or something? Do they need to be reassessed again?
I would say that it's likely that we should be in touch every few months or so, just to make sure things aren't changing.
Right.
Because remember, one must have capacity both at the time that they make the request and at the time of the procedure or the provision.
Well, and you just said the procedure.
Yes.
And I know people are watching this and they've seen movies, they've seen TV shows. People are wondering, do you go to a special place? Is there a clinic? Does a clinician come to the person? What does that look like?
Those are great questions. We always try to meet the patient where they want to be met.
Okay.
In my experience, the majority of people want to have their procedure or provision done at home, in their own surroundings that are familiar and comfortable for them. Now, some people are in hospital and too ill to be moved out of hospital,
Right.
so they may have their provision in hospital.
I'm sure you've met people where they've had a long journey, and they're much more death accepting than maybe others. And when this day was to come, was it treated by some as a bit of a ceremony, as a gathering?
A ceremony or an event, even.
Event,
Yes,
yeah.
people make arrangements. They will toast their loved one with a glass of wine or the very best scotch.
Sure, right.
The patient sometimes dresses in certain clothing. Some people choose to have just a best friend in the whole world with them. Some people choose to have a family of 30, 40 people around them. It's all unique and different.
I'm going to ask this because people are watching this saying, what is the procedure? Is there a series of potions? Is there a special incantations? I'm being goofy now, but is it a series of chemicals? How does it?
Most commonly, it is clinician administered. That
Okay.
is administered either by a nurse practitioner or a physician.
Right.
There is a choice in Ontario where someone may choose to have an oral self-administered cocktail,
Okay.
let's call it that. Very infrequently is that used, interestingly, and I'm not exactly sure why. Most commonly, though, it is clinician administered. That is, an IV is started. Actually, if they're going to have a peripheral intravenous, they'll need to have usually 2 IV lines started ahead of the procedure. That is so that if one were to stop working, then we could quickly switch over to the other without delay.
Okay.
And so there's a series or a protocol of 4 medications. The first one is intended to make the person very relaxed and drowsy. And so in my experience, they fall into a deep and relaxed sleep. Some people start snoring. Actually, a lot start snoring. The second medication is a local anesthetic intended to make the vein numb, because the third medication can sting sometimes.
Okay.
The third medication is normally used as a general anesthetic medication. Let's say you're having your gallbladder out, a certain amount of this medication would be given so that you're asleep or unresponsive, but then wake up after the operation. This dose is such a large dose. It is way bigger than a normal anesthetic dose, intended to create a deep medically induced coma. That is, no awareness of feeling people around, the environment, no sensation, no awareness, period. Right. Most often during that medication administration, the breathing slows down and stops. There is a fourth medication, a neuromuscular blocker, it's called. And if the muscles of breathing or any other muscles are still working or tight, it stops those muscles from working. And generally, from falling asleep with that first medication to not having a breathing or a heartbeat anymore, 6 to 8 minutes, with no awareness whatsoever in the meantime.
Now, Willie, you're describing something that's profoundly life-changing in every aspect. How does this affect you as a caregiver, as a nurse practitioner?
Yes, I wasn't certain how I was going to respond the first time I did this procedure.
Right.
I was a little worried about my well-being, not ever having done anything like this before. I though feel that we all should be given the choice about how our lives end. And I'm really passionate about improving access to this choice. Again, not everyone is going to be eligible.
Sure.
But for those who are eligible, I think it's really, really important that we are given this choice.
Well, Willie, thank you so much for being part of our show today. This has been incredible.
It's been my pleasure. Thank you.